Sorry. Nampak tak ni? Tak nampak kan? Sekejap. Sorry lah. Okay, actually I just finished my Viva, which is my final Viva lah. So now officially Alhamdulillah I passed Viva tadi, so officially I'm a lecturer lah. Because for your information, I'm just a trainee lecturer. So I just 10 minutes ago, so I'm now officially a lecturer. So anyway, so
Congratulations.
okay, Alhamdulillah.
Tahniah, Doktor.
Okay lah. Viva je pun. Anyway, so let's start. Okay, so neonatal infection is very important. Okay, in fact, among all the neonatal pathology, neonatal infection and neonatal sepsis is the most important. Okay, why? Because it contributes to the most mortality. You guys year 5 kan?
Yes.
Yes.
Okay. So basically, okay. So the definition of neonatal sepsis is a clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first month of life. So the keyword is first month of life. It's in fact first 28 days of life. And then it is a syndrome. So as long as we've got the sign and symptoms, then you can say it's a sepsis. Sama macam adult lah. Adult sepsis is with target organ damage, and that's the traditional definition of sepsis. So in baby sama juga. In fact, it's more vague. Okay, sepsis includes septicemia. It can be caused, the source can be septicemia, can be caused by meningitis, pneumonia, arthritis, osteomyelitis, and UTI, or even anything lah. Skin pun boleh buat. Okay, epidemiology. So this is the commonest cause of neonatal mortality, responsible for 30 to 50% of death. Okay, up to 20% develop sepsis, and if you go to the ward, at least 20% of them develop sepsis. And then approximately 1% died of sepsis. So primary sepsis, okay, occurred in 1 to 5 per 1,000 live birth. Okay, especially in very low birth weight infant. When we say very low birth weight, means less than 1,500 gram. Okay, you can clear what's the definition between what's the difference between extremely low birth weight, very low birth weight, and low birth weight infant. Okay, so EO and SNI is early onset sepsis, and 20% for late onset sepsis. Okay, the mortality is 13 to 25%, and more is higher in premature baby. Okay, clinical features. So the features are very non-specific. So the early signs of sepsis are often subtle and non-specific. Okay, the problem is with neonates kan. Neonates is considered a immunocompromised population because they don't have mature immune system lah. They rely mostly from the vertical transmission of IgG from mother lah, especially. They do have quite mature innate system, immune system. However, their adaptive is quite immature. They develop their adaptive immune system later lah, maybe about 3 to 6 months. That's when the adaptive. So that's why in neonates, their response to vaccination is quite poor. Okay. In fact, for example, macam you bagi DTaP kan, you need a lot of booster during neonatal period to make sure they can exert a full immunological responses. Okay, neonatal with sepsis may present with one or more of the following: hypothermia. Okay, they are more commonly got hypothermia than hyperthermia. Okay, lethargy, poor cry, okay, poor perfusion, hypotonia, bradytachycardia, respiratory distress, and metabolic such as hypo and hyperglycemia. If you got question, you can ask me. Just stop me. Okay, specific features related to various system. Okay, it depends on the system lah. If they got sepsis because of central nervous system, then they can have bulging fontanelle, vacant stare, encephalopathic features, coma, seizure, and then if cardiac, they can get hypotension, poor perfusion, GI, hepatic, renal. So it's very vague. Okay, it's very vague. In fact, kalau the neonates who presented with sepsis and tachypnea, it may not actually be the causes, the source of infection may not be actually lung. It can be something else. Okay, because they, for example, acidosis kan, metabolic acidosis in neonates, most of the time will result to acidotic breathing lah, which is the, what you call it, apa, acidotic breathing, apa nama dia? Anyone?
Kusmal ke dok?
Lawi.
Kusma breathing kan? Ya, kusma. Is it kusma? Yeah, kusma breathing, yes. So they become kusma breathing. Even though it's not actually originated from the lung. Okay, hematological skin changes. Their marrow is quite sensitive, so most of the time, infection can contribute to marrow failure. So you get a lot of time patient with neonates with sepsis, they can get thrombocytopenia, leukopenia, and these are actually, and the infection may not actually originated from the marrow. Okay, so we divide sepsis into two, early onset and late onset. Okay, early onset defined as sepsis within the first 72 hours of life. Okay, and late onset after 72 hours of life. Why is important to differentiate between early and late onset? Because early onset almost exclusively originates from mother. Okay, through the process of delivery. It may not be from mother, but through the process of delivery. Okay, most of the time it's through the mother punya genital tract lah. So what sort of infection yang common is STD kan. Kalau mother ada STD, then definitely child can get lah, infection. UTI, mother with UTI, mother with colonization macam GBS kan. So these are the commoner organism that cause early onset sepsis. That onset sepsis is usually from the surrounding. Infant that is who is born in hospital and stayed in hospital for more than 72 hours, they can get nosocomial infection. But those from community, they can get community. So more common is virus. Those from community kan, they can get virus. They can get respiratory bacteria lah. Most of the bacteria is actually respiratory in origin from the surrounding kan. And then presentation, early onset sepsis usually presented with pneumonia, while late onset is more variety lah. They can get septicemia, pneumonia or meningitis. This is the commoner. Kalau you ada soalan, tanya. Okay, what is the characteristic? Early onset usually occur in low birth weight or premature. It occurs in infant of mother with illness. So mother ada febrile illness, ada infection, force myelitis. There is some, usually you can get clue from the history of mother. Okay, mother ni problem lah biasanya. Prolonged labor kan, parental asphyxia. Because actually parental asphyxia is associated with all this lah. Because usually parental asphyxia have some cause, kan, the cause may actually introduce the infection. And then for late onset sepsis, the risk factor include again low birth weight, premature, admission to ICU, mechanical ventilation, invasive procedure. These are all nosocomial. These are all nosocomial. And then the community side, we've got poor hygiene, poor cord care, bottle feeding, pre-lactal feeding. Pre-lactal feeding is a tradition of some of the culture in the world where they give feeding. So in the first hours of life, they give oral feed, such as sometimes dia bagi, macam kita orang Melayu, orang Islam kita ada tahnik kan. But tahnik is only done at day 7 of life. We don't do it at the onset of birth kan. Tapi pre-lactal feeding is given at onset of birth. So dia bagi madu, dia bagi buah-buahan. For example, like the Sudanese, they used to give buah kan, buah-buahan to the infant, newborn infant. Then early onset, the etiology is usually, as I mentioned, GBS, E. coli, gram negative yang daripada UTI, daripada diarrhea, mother with diarrhea, listeria, and then kalau virus, usually the STD lah, herpes simplex, enterovirus kalau mother ada hand foot mouth, for example kan. And then etiology for late onset is usually GBS. Late onset GBS. GBS can become early or become late. And then virus are more common in late onset. RSV, HSV, and some other bacteria lah, pneumococcus, meningococcus, and blah blah blah. Okay, treatment. I'll spend the later lah the treatment. Ada soalan ke? Tanya you guys make sure tanya because I'm going to be quite quick lah. Okay, investigation. Sekejap. Sana. I don't know why the differential diagnosis ni tak ada ni. But later I'll talk about differential diagnosis. So investigation, definitely blood culture, okay, to identify the organism. And again, it's not almost always positive lah. In fact, blood culture in neonates you only get about 30% positive yield. Okay, septic screening include total leukocyte count, absolute neutrophil, immature total neutrophil ratio, and CRP. LP you do in early onset sepsis. Usually we don't do LP lah in early onset sepsis. Okay, but in late onset sepsis, we need to consider LP in all infant with late onset sepsis. Okay, faham tak? Especially bila the infant got like some sign of neurological problem lah, meningitis lah. Okay, for example like breast reflex, which is again is quite is a normal findings in infant newborn to have a breast reflex. So you can look at the look at the clonus, kan persistent clonus or is it just temporary clonus? Or also infant whether any neurological sign lah, nampak lethargic ke, encaphepatic. So this might give you clue that the child got meningitis. So for lumbar puncture analysis, you have to know this. You expect this is a normal. Okay, normal in infant. They've got higher protein lah compared to older children. Infant CSF has higher protein. Bloody tap. Okay, this is a big dilemma especially among neonatologists, because what happen is it's sometimes a bit challenging to do LP in infant. It's actually not as difficult as doing LP in older children, but because sometimes for example if the infant is very small, the area for LP is very small, kan? So sometimes you miss. And you get traumatic LP. However, HSV is very common in infant. In fact, infant born with especially early or even late onset sepsis, one of the culprit is actually HSV. Okay, human simplex virus. And problem with HSV, if you got HSV meningitis, most of the time you'll get blood. Okay, you get blood in the LP. Not because of traumatic, but because of herpes encephalopathy. Okay, so sometimes it's a bit dilemma lah, whether you want to label this as traumatic or you want to take it as true findings. And then other investigation include urine culture. Okay, this is especially for late onset sepsis. Early onset sepsis, we don't actually do urine culture. Radiology, definitely you have to do, depending on the signs and symptoms. Okay. Management is supportive. The main management for sepsis in infant is actually supportive. The principle is start antibiotic early and stop when there's no indication. So start early, stop when there's no indication. You have to start early at the onset of suspicion. Whenever you suspect a child with sepsis, regardless, even though you don't have any evidence, you have to start antibiotic because these are vulnerable population. They are immunocompromised. Okay, so and the rest are actually just supportive lah. Make sure maintain the thermoregulation, oxygen saturation, ventilate if need be, and then hemodynamic monitoring, sugar monitoring, volume expansion if patient in shock, and then PEC cell. Remember, I've mentioned that the newborn marrow are very sensitive. They're very fragile. So any sepsis can actually lead to marrow failure. So they have lower threshold for transfusion compared to all the children. Okay, the definite management is antimicrobial therapy, but again, you don't wait for cultural results to start antibiotic, especially in immunocompromised population like this. Okay, so start based on the routine practice or the guidelines in your local area lah. Because especially if you are in ICUs, most ICUs practice rotation, antibiotic rotation. So because this is to prevent resistance, emergence of resistance organism. Okay. So how long? It depends. If you think this is meningitis, without you need to do LP, and then based on that you decide lah. But usually in infant, meningitis is 21 days. Okay, if blood CNS positive without meningitis is 14 days, especially if this is gram negative. Because you know gram negative organism, they tend to invade your brain. Okay, they tend to cause meningitis rather than gram positive lah. And then if this is probable sepsis, which means you don't have confirmatory positive culture from your LP or from your blood, then you have to treat for 5 to 7 days. So indication for starting antibiotic, okay, this is empirical antibiotic. For early onset, any infant with more than 3 risk factor. The infant may be well, tapi dia ada 3 or more risk factor. For example kan, the child is premature, late preterm, 35 weeks, for example. And then low birth weight is 2 kilo. And then on top of that, mother got false mainly aqua. And mother got fever. So you've got 4 risk factors kan. Even though the child born vigorous, active, no hypoglycemia, no sign and symptoms of clinical sepsis, you have to treat the child with antibiotic. And then presence with false smelling liquor. Any child who born with false smelling liquor, you have to treat with antibiotic. Any presence of 2 antenatal risk factor and a positive septic screen. What do you mean? What do I mean means, for example, the child has actually is 2 or more, bukan more than 2. For example, the child is late preterm, 35 weeks, okay, and then mother got leaking liquor more than 24 hours, PPRM more than 24 hours, and then the total white is 30. Then you take blood. Okay, you take blood, total white 30. Then definitely this child has to be admitted. And lastly, strong clinical suspicion. For example, the child is well, but then suddenly got hypoglycemia. This is not in form of diabetic mother, well child, suddenly after like few hours of life, ada hypoglycemia episode. Ataupun ada vomiting episodes. So you have to start antibiotic. How about loss? If you got positive septic screen and strong clinical of sepsis, then you have to start. So empirical antibiotics, mainly we use that cover the community acquired. Okay. Because you have to understand, the early onset sepsis are actually community acquired, just like the late onset sepsis. Because they get the infection from mother, cover them, these 2 populations we have to cover with ampicillin, with penicillin group, and also a narrow spectrum antibiotic that can cover the gram negative. Usually the macrolides lah, gentamicin ataupun biasa gentamicin lah. So the gram positive, narrow spectrum gram positive macam ampicillin, penicillin will cover the common gram positive, while the macrolide will cover the common gram negative. So there's no role for prophylactic antibiotic. So we use empirical antibiotic. Empirical means you've got suspicion, then you start antibiotic. That is empirical, without the definite diagnosis. Prophylactic is you don't have anything, the child has no risk or nothing, you start antibiotic. That is prophylactic. So there's no role for prophylactic antibiotic. Okay, remember kalau ada exam tanya, prophylactic antibiotic is a must for infant with, contoh for infant with dash prem. Is it a must? No. Okay. It's not a must for prophylactic antibiotic. For example, you've got a child kan, you've got a mother who had bleeding placenta previa. Okay. No other risk of sepsis, bleeding placenta previa, and deliver a 30 weeks old baby or 30 weeks baby kan, 30 week gestation baby. Do you have to start antibiotic? No, not necessarily, because we don't use prophylactic antibiotic. But if you got another woman who delivered a 30 weeks old baby because of premature contraction, premature labor, PPRM, then you may have to think, why this lady got PPRM? Is it because UTI? Is it because mechanical dia jatuh ke? Ataupun is it because it's usually mesti ada something kan, massage ke? Contohlah, the woman went to see a witch doctor, for example, and then dia buat massage of the abdomen, and then baby delivered. Then you may not start antibiotic because you know this is a mechanical problem. Okay, faham kan? Okay, sana. So baby that you think acquired the infection from hospital, then you need to cover antibiotic that can actually cover most common organism in the hospital. For example kan, kalau baby tu born, for example, if you work in a center where there's outbreak of ESBL, definitely baby yang ada kat dalam tu, if they got sepsis, you have to cover with antibiotic yang boleh bunuh ESBL. Okay, faham kan? Okay. Okay lah. Most of the time we use a broad spectrum bactalactamase together with negative gram-negative coverage. So our common, for example, macam kita punya NICU, kita punya second line for nosocomial is actually tazocine and amikacin. Okay. Or some center they use third generation cephalosporin lah, macam cefotaxime, and also broad spectrum penicillin. Usually cefotaxime alone ataupun dia tambah broad spectrum gram positif macam tazocine. Macam tu lah. Remember, if you suspect meningitis, then you have to cover with antibiotic that can penetrate your blood-brain barrier lah. Blood-brain barrier such as cephalosporin group. Kalau kita nak guna cephalosporin group, you boleh guna high dose penicillin, because in neonates, high dose penicillin can actually penetrate your brain. Tapi kalau macam people like us adult kan, kalau I ada meningitis, you bagi I penicillin, then it's useless because penicillin cannot penetrate the blood-brain barrier of adult because this is a already well-formed blood-brain barrier. Okay. Okay lah. So management, okay lah. If you suspect, if the child got like, if the baby has been a while in the hospital, got central line kan, got umbilical catheter or got central line PICC, then you may need to cover with antibiotic that covered CLEP-C or CRBSI, catheter related bloodstream infection, or catheter CLBSI lah, catheter bloodstream. Okay lah, CLEP-C. So the use of aminoglycoside is common, okay, especially the genta and also amikacin, because aminoglycoside, the resistance pattern is very low lah. Not many organisms actually resistant to aminoglycoside. They've got very good gram-negative coverage, and they penetrate well to most of the organ. So kalau macam UTI, kalau you ada pleural effusion, kalau you ada abscess, then these agents are very good. So the disadvantages is ototoxicity, nephrotoxicity. You need to monitor level, and then itulah. So reserve antibiotic, you have to reserve some newer antibiotic, or maybe for example vancomycin you reserve for those with MRSA kan. Macam meropenem you reserve untuk those yang ada ESBL, for example, extended beta-lactamase producer. How about herpes? Again, herpes is very important in neonates, but it's quite common. It's quite common, in fact, it's very common, and it causes a lot of mortality lah. Okay, Usually, if patient got fever, okay, fever, and then ada hepatitis or jaundice, meningitis, the seizure, thrombocytopenia, vesicles, rash, this might actually point you to herpes, possible discharge got herpes. Then you have to cover with ganciclovir. Okay. So HSV in neonates, you've got 3 types. You've got the skin, eye, mucous membrane manifestation. You've got isolated CNS, which is the encephalitis, or you've got the disseminated sepsis. This is the worst prognosis. So HSV, usually if at birth they've got HSV, they will get this skin, eye, mucous membrane disease lah. This one, look at the baby kan, dia ada herpes, kita panggil herpangina lah, herpangina on the in the mouth, around the oral cavity, SEM, skin, eye, and also mouth, mucous membrane. And then in the isolated CNS, if the child already 2 to 3 weeks presented with meningitis, then you have to think of herpes. Tapi kalau usually more than 1 week, they can present with, most of the time they present with disseminated lah, bacteremia, sepsis or shock. Okay, this one, I don't think why, this is not important, this is important, but you don't need to know lah. No, you don't need to know this. Okay, no, okay. Later I'll share you the slides and then you can read lah, because HSV ni we sometimes exaggerate lah, But remember, if you suspect HSV, you need to treat, because the long-term sequela is disaster. Okay, almost all patients with HSV, they can get deafness, sensory neural deafness. Okay, so you need to treat. Okay, a lot of them, they've got encephalitis, and then they've got they become CP and some other blindness. So it's very important to treat. So any suspicion of HSV, start acyclovir, start treatment. Ada virus infection, ada torches, and also varicella. Okay. Habis dah? Oh, that's all. Okay, surprise. I know this topic is very boring. In fact, I don't like this topic. Anyway, this is very important. This is not important, it's not common, but this usually coming in the exam. When we talk about herpes and HSV infection in neonates, we're looking at this. Okay, this is the typical classical CT-MRI. You can get this maybe in your OSCE something. Temporal lobe lesion. Okay, baby datang with encephalopathy or datang with seizure, and then we did CT-MRI. Look at this. Then what's your diagnosis? Then this is HSV. Or you can get by EEG. Besides you do like imaging, you can also do EEG. You can get this PLAT. Okay, PLAT changes. Okay, PLAT is posterior lateral epileptic discharge. Remember, posterior lateral epileptic discharge is quite specific. It's not specific, but it's quite sensitive for herpes. Okay. So it's good because the problem is herpes PCR negative doesn't rule herpes. Okay, so if you do LP and then you send for herpes PCR, it comes back negative, it doesn't rule out herpes. Okay, so you need other investigations such as imaging or EEG. Because why herpes is very important, it's treatable, and the sequela is disaster. Okay, any questions? Sorry lah, I know it's a bit boring lah. Okay, nowadays we're talking about COVID kan, COVID in neonates. Actually a lot of study done. So we know COVID definitely doesn't transmit through breast milk, doesn't transmit through EBM. There's no evidence on that. And in fact, most baby yang ada COVID, they survive. Okay, even though in pediatric in general, I mean their resistance, not resistance. I mean their the COVID doesn't affect them much. However, among the pediatric population, those the neonates has the worst prognosis. Okay. In fact, among the pediatrics kan, those with cancer, immunosuppressed kan, yang on chemotherapy, they were not affected so much with COVID. Okay. Okay, any questions? I know this is a boring topic. I don't know whether you like it or not, but this is very important.
Like to ask yang dekat slide clinical feature yang pasal GIT, direct hyperbilirubinemia is especially dengan urinary tract infection. I mean, how can the UTI specifically cause direct hyperbilirubinemia?
Okay. Frankly speaking, I'm not sure why. Okay. In fact, there's a lot of theory why. Try to explain this lah. But the main thing is, it's usually because of clearance. Direct is, yes, it's usually because of clearance. You have to understand kan, how do you clear your bilirubin? You belajar kan physiology kan? Metabolism kan? So how do you clear your bilirubin? Siapa yang tanya tadi?
Siti Jata.
So how do you clear your bilirubin?
From urine and feces.
Okay, how was that? How is that? So from liver, okay, from liver, bilirubin transferred to liver and then conjugated and then become what?
And then become urobilinogen and stercobilin.
Okay, good. Urobilinogen and stercobilin. Then lepas tu what happened?
And then
remember, these are all conjugated hyperbilirubinemia, which or the other name is direct bilirubin. So these are all direct bilirubin or conjugated bilirubin. Okay. So from liver, okay, they send to become urobilinogen and stercobilin. And then at the bowel, okay, they some of them will be reabsorbed back to the blood. Okay, reabsorb back to the blood and go to your urine kan? Go to urine and will be excreted as a bilirubin lah. Dia akan excreted as urobilinogen. Contoh, I tak ingat nama. And then, but most of them will be excreted through feces. Okay. If you got UTI kan? If you got UTI, it will affect your excretion of bilirubin. So that's one of the theory lah. That's one of the theory. So what happened is, you get conjugated hyperbilirubinemia. Faham tak? Okay. Itulah. And besides that, yang ni kalau direct, okay, kalau infant who's been well, okay, you've got a child, a baby who's been well, day 5 of life, suddenly become jaundice, what we call rebound jaundice kan? You have to think of sepsis. Okay, in a child with rebound jaundice, you have to think of sepsis. Again, you have to understand the physiology of bilirubin clearance. If the child got sepsis in the bowel kan, dia ada feeding intolerance atau dia ada bowel pathology, so dia akan ada problem dengan reabsorption of urobilinogen, so dia tak boleh excrete through urine. Okay, itu satu. Atau, okay, or the child get, when they got infection kan, dia ada hypoperfusion or they've got acidosis, metabolic acidosis, which can actually displace, okay, metabolic acidosis, okay, the hydrogen ion, they can displace bilirubin from albumin. Okay, you have to understand, the indirect bilirubin or the unconjugated bilirubin, they are carried by albumin. Okay, albumin is a negatively charged molecule, so it will attract positively charged ion, such as hydrogen. Okay, such as hydrogen ion. Some medication macam furosemide has to be carried by albumin kan. Bilirubin is a positively charged ion molecule, and it will be carried by albumin. So when you got acidosis in the blood, more hydrogen will be carried by albumin, so albumin will displace your bilirubin, so you will get rebound jaundice, and most of the time is a rebound indirect jaundice. Okay, faham tak? So kalau you ada baby yang umur dia 5, 5, 6, 7 days has been out of jaundice kan, suddenly ada rebound jaundice. then you have to think of, is it dehydration? Dehydration, so you you reduce clearance of bilirubin, ataupun is it sepsis? Most of the time, rebound jaundice you have to cover with antibiotic. Okay, faham? Itulah kalau this is a face to face, then I boleh draw lah sikit the physiology, tapi sebab this is online kan, so susah sikit lah. Okay, anything else? Saya ada soalan?
Ada ke?
Tak ada lah.
Yang dekat soalan dia tanya pasal yang lumbar puncture tu. Kan doktor cakap kalau late onset all must do lumbar puncture. So kalau regardless tak ada meningitis symptom.
Okay, dia macam ni in neonates kan, we don't really rely on symptom and signs. Okay, we don't rely on symptoms. We rely on the suspicious from history and physical examination and a lot of other consideration you have to put in. LP is not a must. Okay, definitely is not a must for late onset sepsis. However, even a tinge of suspicion kan, you kena buat LP. You kena cover for meningitis because it's disaster. Okay, meningitis in neonates almost certainly will cause without treatment almost certainly memang akan death. Almost certain. Okay, the worst they can get hydrocephalus, they can get vegetable lah, bukan vegetable. So definitely you have to do LP in any child of late onset sepsis with suspicion of meningitis. Okay, faham? Bukan semua tapi majority dia sepatutnya kena. In fact, actually LP is the first line investigation untuk late onset. Tapi masalahnya ialah kita tak in Malaysia it is not routine practice lah. Tapi in overseas kan, some center LP is something yang routine dibuat. Cuma remember once you do LP, okay, you have to understand you are damaging the mechanical barrier. Kan? Because the skin is a mechanical barrier to protect you against infection. Once you do LP, okay, you compromise the barrier, so the child will has risk of dapat meningitis from your procedure. So that's why in neonates or even in pediatric, anyone who had LP done, despite the LP results, they need to be covered with antibiotic that can penetrate your blood-brain barrier for at least 5 to 7 days. Faham tak? So you treat them not because meningitis, you treat them because you did LP. Faham? Faham tak? Okay, kan? Okay, any other questions? Okay, ada soalan? Ada soalan tak? You guys ni scary lah. Senyap je.
Macam tak ada.
Okay, I'll share you guys with the slides. Kalau you ada soalan, you just text me lah. Okay, in fact, because this topic is very dry, we can make it more interesting kalau face to face lah. But however it is, you have to understand the take-home message is first, neonates are immunocompromised population. Okay, you need a very minimal or very low suspicious of sepsis, to start with antibiotic, empirical antibiotic. Okay. And third, you have to identify patient with risk of sepsis and sign and symptoms of sepsis. The sign can be anything. For example, if I got a child, I admit the child and I start antibiotic, no one can question me. For example, I just said, the child looks tak active lah tadi, so I start antibiotic. This child have no risk factor, tapi in my eye, the child is not as active as normal other baby, then I can start antibiotic and no one can actually question me. Okay? Because the principle is, in immunocompromised population, you start antibiotic early, you stop when it's not indicated. So you buat antibiotic, you bagi antibiotic, and then you buat investigation, you certain there's no sepsis, then you can stop. So it may like take 24 hours or 48 hours before you stop the antibiotic. Okay, faham eh? Okay, later I'll share with your rep the slides, and then you ada soalan, you boleh tanya je lah. Okay, ada ke last soalan? Okay, tak ada? Okay, tak ada, kita stop lah. Kita tangguh dengan tasbih kafarah dan suratul asr. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Salam, thank you, doktor.
Okay, doktor.
Thank you.